So today is the sixth day, and one more tomorrow.
We are live now, doctor.
Okay. Hello and welcome everyone for the live webinar of Glaucoma Society of India. Today is our sixth day program. Today we have two master speakers, Dr. Mayuri Kamar from Gujarat and Dr. Pradeep Vyas from Indore. Both of them are very, very senior faculties, and there's so much of knowledge loaded in them. So we are going to hear them talking about the gonioscopy part of it in a little bit detail from Dr. Mayuri Kamar. And when you have an advanced glaucoma, how we can really manage these cases is done by Dr. Pradeep Vyas. Without much delay, I'm going to request Dr. Mayuri Kamar to start her topic. Over to you, madam.
Is it same?
Yeah, we are still, just make it as a full page. Yeah.
Okay.
Yes, madam, we can see your slide as well as we can hear your voice. You can go ahead with your talk.
At the outset, I would like to thank Dr. Satyan and Dr. Manish and GSI for giving me this opportunity. I'm going to share my views on the gonioscopy and anterior segment imaging for the glaucoma diagnostic and management. Why should we do this gonioscopy? It's a fundamental part of the comprehensive examination done initially for all glaucoma patients, glaucoma suspects, or whosoever enters our OPD with a shallow anterior chamber. It requires repetition periodically, helps in grading the anterior chamber angle, but most importantly, helps us in differential diagnosis of secondary glaucomas. In childhood glaucoma, it is helpful in diagnosis as well as it provides a prognosis. It also helps in assessing the change in the angle morphology after doing procedure like LPI. And the knowledge of gonioscopy, good gonioscopy is must when you want to treat the angle in form of laser trabeculoplasty or you want to do angle-based MIGS. Now, there are various methods of doing gonioscopy. Indirect gonioscopy, which can be a dynamic gonioscopy in form of indentation or manipulative gonioscopy, and direct gonioscopy, which is useful while performing the surgery. The informational goals for primary glaucoma is this angle open or closed in its natural position? If angle is closed, is it a positional closure or cynical closure? And if it is open, is this angle is occludable for the future? So when we interpret the gonioscopy, we look at the angle structure visible, which decides on the narrowness and openness of the angle. Iris configuration and patterns will give us occludability as well as the syndromes and abnormal features like pigmentation, blood vessel, etc. should also be seen. Back to the basic, let us see, we are using a mirror. So whatever we see is exactly like a mirror in the opposite direction. One of the examples shown here is the blood vessel seen at mirror inferiorly at 7 o'clock will be seen at 11 o'clock. It should be at 11 o'clock in the eye. Now, precise identification of all angle structure is must. The anteriormost part, which is a white prominent shiny line, is Schwalbe's line. Then is the trabecular meshwork, which is divided into anterior non-pigmented and posterior two-thirds in a pigmented meshwork. Then is the white band or white line, which is scleral spur. And lastly, the gray zone is ciliary body band. Various gradings and systems or classifications are available. One can use any to their convenience, but basically speech system is based on three variables: angle width, site of iris insertion, and peripheral iris curvature. The configuration of peripheral iris is divided again as a steep, which is typically seen with the pupillary block type of glaucoma, regular or pure or concave iris configuration seen with the myopic eyes or the pigmentary glaucoma cases. Now, angle width is the estimated angle between the line tangential to the trabecular meshwork and a line tangential to the surface of the iris. So, grading of the angle is decided like which is the structure visible. The first photograph is showing grade 0 angle, where the iris is in direct contact with the cornea. Grade 2, where part of the meshwork is seen. In grade 3, you can see the scleral spur. And grade 4, where you can see the angle recess also. Now, manipulative gonioscopy is done when you are using Goldman 2 mirror or 1 mirror, where there is an occludable angle. You can manipulate this gonioscopy in form of, you ask patient to look into the direction of mirror. Suppose mirror is superior, you ask patient to look up and then tilt the lens towards the center. This will give you over the hill appearance of the antechamber angle. Now, this is the classic example of manipulative gonioscopy. You can see the zeroed angle. On manipulative gonioscopy, the angle opens up. Now, indentation gonioscopy is done with the 4-mirror gonio lens, which is a smaller lens with a almost flat base of the cup. And when you indent in the center of the cornea, actually it rises the intraocular pressure in antechamber, pushing the aqueous in the periphery, and subsequently opening up of the iridocorneal angle mechanically if it is oppositional closure, and no opening if it is a cynical closure. The indentation or the dynamic gonioscopy enables us to differentiate between the true angle closure or the appositional angle closure. And it also identifies the plateau iris configuration or lens-induced angle closure. The disadvantage of this is one should be master in the proper technique. It has a learning curve and tendency to steady the lens on the cornea makes you indent on the cornea and so underestimate the narrowness of the angle. Now, this is an example of indentation gonioscopy. The angle was 0, but it opens up on indentation. Here you can beautifully see the double hum sign of the plateau iris configuration. Another example to show you how on indentation you can open up the angle if it is oppositional closure. Even when you have a angle which is heavily pigmented, or when you have a non-pigmented angle, you can use the corneal wedge or apex. So where the apex is a shawl base line. And this is useful particularly in non-pigmented eyes where you are confused where exactly is the, and this is a pigmentary glaucoma, densely pigmented meshwork may confuse somebody. So, and after doing this, you have to put down the records of the gonioscopy. So first, in 4 quadrants, put down the most posterior structure visible. Here it is scleral spur, so write down that, or the ciliary body, like that. Then is the pigments in the meshwork according to the grading, and the configuration of peripheral iris in each quadrant, whether it is flat, convex, or concave. And then after doing this, you have to find out if there are any abnormal findings in the antechamber angle and where it is. So this is a classic example of the pigmentary glaucoma. You can see the grading of the angle. Very, very minimum pigmentation, that is grade 1. This is grade 2 pigmentation. You can see all the angle structures here. And this is a pigment dispersion syndrome with a Krukenberg sign. And the pigments you can see is the grade 3. You can see the scleral spur. If it is grade 4, no angle structure is visible. This is an example of postoperative secondary glaucoma, you can see the iris is studded with the jet black pigmentation. On gonioscopy, the same jet black pigmentation is occupying the whole angle. So next is the iris process. Their lacy cord follows the depth of the angle and it moves backwards on the indentation. Should be differentiated from the peripheral anterior synechiae. And then creeping of the anterior chamber angle. The peripheral anterior synechiae, they are broad, pent up and taut and going up to the Schwalbe's line. While goniosynechiae, they extend up to the meshwork, but never up to the Schwalbe's line. And creeping angle closure with this type of pigmentation, patchy pigmentation and bizarre pattern can be seen at times. And eye syndrome, you can see the anterior insertion of iris with the stromal atrophy in the nearby area. Now, angle recession glaucoma or post-traumatic glaucoma is another variety. And you can see the recessed angle here. There is a cleft between the longitudinal and circular fibers of the ciliary body. And note down, the anterior chamber angle is here, but this is the recessed angle. Sometimes you can have a black ball sign, which is a suggestive of previous hyphema. And always compare both eyes and look at the depth of the anterior chamber. And note down how many quadrants is been having angle recession. Pseudoexfoliation glaucoma is again having patchy pigmentation. The pigmentation is more than normal, but sometimes you can see the white dandruff material in the angle. This is another example showing the packs in the window. You can have huge material, lot of material of the packs in the angle. These patients may have a symphylosis line. Normal blood vessels in the angles, usually they are solitary in nature, broad and appears in a short segment. Never extends anterior to the scleral spur. Should be differentiated from the abnormal vessel, which are fine and superficial branching, extends anterior to the scleral spur and arborization in the trabecular meshwork. And you can see the extension on the iris surface also. Now, this is a patient, young patient with a recurrent attacks of the glaucoma in the left eye. He was referred to us. While performing the gonioscopy, we found out that the patient had a patchy pigmentation nasally. And while doing the photography, I could see that something was wrong in the other angle. You can see the blood appearing in the angle area, and gradually the whole angle was filled up with the fresh blood. This is typical Amsler sign. So it was a case of Fuchs heterochromic iridocyclitis. You can see the typical iris pattern in this patient. They are unilateral most of the time. So gonioscopy helps in identifying many other conditions like this. The nevus or any tumor in the angle or foreign body should always be documented for the future follow-ups. This was a case showing the bump in the angle. It was only in one quadrant. So we did the UBM in this patient and found out that there was a ciliary body cyst. On full dilatation, we could see the ciliary body cyst. Silicone oil glaucoma is very easy to see. Silicone oil in the crypts of the iris as well as in the angle. And then is the pediatric patient or childhood glaucoma. This was a typical case of childhood glaucoma. I don't know what is happening. And this is another case showing you the anterior insertion, high insertion of the iris, and has a bizarre pattern, mesodermal dysgenesis. This was axon-filled anomaly with the cord-like Schwalbe's line in this area and broad attachment in this particular area. So gonioscopy can also has a many other use, like SLT or the ALT can be performed using the gonioscopy. Post-surgical assessment is possible, and you can see the angle opening after doing that. Now, this is a classic case showing you the stent in this area or tube. We were unable to see nicely in the anterior chamber angle, but while doing the gonioscopy, you can see the tip of the tube in the anterior chamber. This was one of my patients who had bilateral hydrus done in USA, and you can see the malposition of the hydrus in this particular patient. So other eye, when you see, it gives you the prognosis. If one eye has a PI and patient has a glaucoma, always do the gonioscopy of other eye, or it is to be performed in the siblings also when there is a positive history of glaucoma. And never forget to see the disc through the central mirror. Anterior segment imaging is a quantitative, qualitative, and subjective assessment. And imaging device may provide more objective assessment of the anterior chamber angle, but it is not the replacement of the gonioscopy. Gonioscopy is essential in all the patients of glaucoma. Now, how it helps? It's a consistency of the image generated is far better and reproducible at any time. And because it can be done in the dark environment, so it allows greater sensitivity in identifying the eyes with the oppositional angle closure. It is a non-contact, non-skill dependent, gives you objective measurement with minimal light artifacts. So these are the 4 gadgets available to us: ASOCT, UBM, iCam, and Cassia 2. And ASOCT is similar to B-scan ultrasound, but uses light instead of the sound to image the tissue. The resolution is axial depth is 18 micron, while lateral transverse is 60 micron. UBM has ability to visualize the posteriorly located structure, which is not possible with ASOCT. And it is also, this technique is useful to investigate the mechanism of angle closure behind the iris. And the same thing, electrical signals are converted into either 50 megahertz or 25 megahertz frequency ultrasound sound waves. So first identified the landmark of the iridocorneal angle while doing the ASOCT. The first one is the scleral spur, where there is a change in the curvature, that is scleral spur, and then the angle recess, which is just behind it. And this technique will give you iridocorneal tools. Various measurements can be procured by using this technique. It could be angle opening distance at the various distance, 500 at 750, or angle recess area, or tease-up, or polygonal area. AS imaging is useful in angle closure glaucoma to know the extent and mechanism of the angle closure and to understand the physiological variation of the angle. This is a classic example of pupillary block glaucoma. There is a steep configuration of the iris here. And this is an example of the phacomorphic type of angle closure glaucoma, or tabletop sign, so nicely seen for the plateau iris configuration. If it is acute angle closure glaucoma, by doing UBM, you can see the ciliary body effusion, which might precede and contribute to primary angle closure attacks. Now, another mechanism is posterior pushing mechanism. Spherophakia is a classic example where the lens is pushing the iris forward. Here, pupillar PI may be questionable. Another one is the plateau iris configuration because of the forward rotation of the ciliary body processes and ciliary cyst. One more example is the pigmentary glaucoma, where there is a reverse pupillary block, which is nicely seen in this particular patient. And these are the patients where PI may be a beneficial. Another advantage of seeing this angle recession or the dialysis or cyclodialysis left, if patient has a fresh trauma and hyphema, you can use this technique to see the angle structure. In pseudophakic glaucoma, it is good to use ASOCT or the ABN because here this particular patient, you see the one part of the haptic is in the back while here it is in the sulcus. And this will give you the irritation of the haptic to the ciliary body and rubbing of the haptic to the iris. So another advantage of usefulness of ASOCT is physiological variation of the angle. This is a case of occludable angle. You can see the narrowing of the space here and here with the lights on with the small pupil. But when you put a light off, there is a opposition or iris is touching to the angle. So there is a occlusion of the angle. So these are the dynamic changes you can see using this technique. Again, iris volume and configuration can be calculated. This is iris volume is increase after pupil dilatation in narrow angle eyes, which predisposes to acute angle closure glaucoma. So this is also one of the thing, but more of a academic purpose. Lens wall can also be calculated using this technique, and then one can determine the likelihood of success in opening the angle by removing the crystalline lens. When you have a hazy cornea or the nothing is visible and you are planning keratoplasty, for example, this patient, then by doing the intersegment imaging, you can find out how is the angle and what is there on the back side. Then Sarkis analyze the PI, whether it was patent or not. By using this technique, you can see the PI is present and the line surface is also seen. So lastly, evaluation of the procedure that you have done. This is a case just before the PI, a very shallow chamber, and immediately after PI, you can see the gush of the aqueous coming anteriorly and opening of the angle with a increase in the depth of the angle that can also be calculated. In vitro evaluation of the functioning of the trabeculotomy bleb using this anterior segment OCT is done by me in many patients. And at the end of 1 month, we found out that if there is a multiform reflectivity of the bleb wall pattern or multiple internal layers, if there is a subconjunctival separation, and if bleb has a microcystic, any of this, these blebs are going to be successful at the end of 6 months. If the bleb is having hyperreflectivity areas like this, these are the blebs which are likely to be failed in the future. So this needs any other modification like needling or 5-FU injections. Or this is a classic example where there was a flat bleb hyperreflectivity and the pressure were going upwards. So we release the releasable suture. Immediately after the release, you can see the elevation with the multicystic wall. Similarly, you can see the position of the tube or the implant that you have done. What is the shortcoming of this imaging? You cannot see pus, pigmentation, blood vessels, etc. So there you need the gonioscopy. This provides structural assessment and not the functional. And dynamic changes cannot be done in form of indentation. So take-home message is use AS imaging as a complement to gonioscopy, not as a replacement. Thank you.
Wonderful, Dr. Mayuri, madam. Wonderful talk and wonderful slides, wonderful photographs. Gonioscopy as well as the anti-segment photographs were really, really nice. I hope people take a lot of lesson from that. And I hope we all can do a wonderful photography of the gonioscopy. So we will just go with Dr. Pradeep's talk as well. and then we'll have the discussion done. So really, thank you so much, madam. And I think you have proved me that I'm not wrong in giving you this particular topic. Wonderful. Excellent. Over to Dr. Pradeep for your talk, and then we'll have the discussion.
Yeah, good evening, friends. And thank you, GSI, for having given me the opportunity. Are you seeing my slides?
No.
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 Can
Yes.
your
Screen has come.
screen? Yeah.
Okay.
Just probably have to open up your slide. I think it is last few rows, the top from second line. Yeah, the third row, last, yeah, third row, second one, third row, second one.
Third
And
row.
from this side, from right to left when you come, in your desktop, from right to left, the third row, second.
No.
It's here,
Here?
just above.
Above that. Above that.
Yeah.
Yes, yes.
Left second on the top.
Just a minute. I think I have closed the window. Okay.
Yeah, you can just go with the full page. Yeah.
Are you seeing it?
Yes, yes, I can
Yes.
see, and then I can hear you as well.
Okay. So I would be talking on the management of advanced and end-stage glaucoma. What you are seeing on your left-hand side, in this disk, you can see that the vertical is almost near total cupping and horizontal is almost 0.8, and there is a significant RNFL loss. While on this disk, you can see that there is hardly any neuroretinal rim or the RNFL is left. So on the left-hand side, what you are seeing here is the advanced glaucoma, and what you are seeing over here is almost an end-stage glaucoma. This is the perimetry where in the advanced glaucoma, the horizontal meridian or the fixation is compromised. And in end-stage glaucoma, you see a very narrow island of vision left. In many patients, this is a very useful vision. So, the question is that why the patient reaches to that level, uh, still we are not able to diagnose, or the patient is ignorant. So the most important thing is that many of these patients, they have a unilateral condition. And all of us knows that the glaucoma is an asymptomatic disease, so they are not able to realize that they are losing the vision in the one eye. And when they present to a doctor, it's in a very, very advanced stage or in an end stage, and the other eye is the normal eye. But there are many patients who have a bilateral condition. In our OPD, almost two, three patients of that sort comes every day for their follow-up. So how they reach to this stage? Because they are ignorant, they are negligent, and they remain undetected till the end because they don't visit to their ophthalmologist. Sometimes the pathophysiology of the glaucoma is a contributory factor where the glaucoma is progresses very fast. Like you can see in this patient, because this patient was under close follow-up, so it's why we can pick it up. Otherwise, if the patient is little ignorant and has not reached to their ophthalmologist, then the progress is very fast to the end stage glaucoma. These are the few conditions where the patient progresses very fast, particularly the angle-fissure disease, which is very common in Indian population. Childhood glaucoma, invariably, they are in a very end stage glaucoma. food exfoliation, pigment dispersion, neovascular glaucoma, eye syndrome, UVI take. They are the few other conditions where patient progresses very fast. Post-VR surgery is the another condition created by our colleague where the patient progresses very fast to the end-stage glaucoma. Failed anti-glaucoma surgery, and if the pressure goes very high, these patients also lands up in end-stage glaucoma. Traumatic, as I said earlier, there are many patients who have a condition in one eye and it's a painless condition, so they never know that they had a trauma. And when they visit their doctors, so the patient is at end stage glaucoma. So from patient perspective, they always have a fear of going blind, and that is very genuine. It is very likely that the patient may go blind if the patient is still negligent, ignorant, and poor compliant. Their quality of life is significantly affected, and they are always dependent on the escort or the domestic help, and there are lots of financial issues involved as well. From doctor perspective, it's a very challenging condition. The first, we have to counsel the patient. We have to let him know or let her know that what is the condition and what could be the prognosis if the patient is poor compliant and non-compliant. So we have to make sure that the patient remain compliant, and we have to struggle very hard to preserve the remaining vision, and if possibly patient can maintain a little bit good quality of life. So how to diagnose this? Obviously, the clinical examination is very critical, visual field evaluation, and imaging technology. Look at this field. What we advise to our patient, routinely we advise our patient to go for 24 days 2 programming. But in 24 days 2 programming, because the resolution is very poor, so that's why the floor is very close. And when the floor is very close, they touches the floor very fast, and this strategy is useless for these patients. Look at here. If we adopt the 10-2 strategy, it is very useful for this patient. Compare this in this 24 days 2 in central 10 degree, which is very critical in this patient. We just test 12 points and the resolution is 6 degree, while in 10 days 2 strategy, we test 68 points and the resolution comes to 2 degree. So that's why we get a little bigger area, and that's why we can assess it properly and we can assess the progression of the condition. So that's why in all these patients, make sure that you are adopting the strategy of 10 days 2. And how to assess the progression in these patients? You have to monitor and compare each and every field at every visit. So you have the overview printout. By getting the overview printout, you can see that how the patient has progressed over a period of time. To look at the progression, if there is a 1 decibel decrease in the mean deviation, that is significant in this patient. Look at here, this patient has gone from 31 to 32, but it has progressed significantly in 2 to 3 years' time. So the imaging. So we have been hearing in a few lectures that, we should not go by the color coding. All color images are useless, and particularly so in the advanced or end stage glaucoma, where you get all red and all red. This green, what you are seeing is basically because of the remnant of the glial tissue, but there is nothing left in the nerve fiber layer. That is all gone. Why it is so? Because still the patient retains some vision, but this is all red. The simple reason is that their floor, they have reached to the floor, and the floor in this patient is somewhere around 50 micron. Probably the macular imaging might be little beneficial in this patient because the floor in the macular area is little lower. It is around 40 micron. Why so? Because glaucoma is a disease of the ganglion cell, and most of the ganglion cells are concentrated in the macular area. Almost around 50% of the total ganglion cells are in the macular area. So when we image the macular area, probably it is little helpful as compared to the what is we image the ONH and the RNFL. You can look at over here the NFOS image, and you can see that there is a significant thinning of the RNFL over this area. And the floor is 40 micron, and this patient is at around 60 micron. So still we can image this patient and we can assess the progression on subsequent follow-up. But the OCT angiography is probably a better tool to assess the progression, because in these patients, the floor is further lower down. We can do the OCTA for the parapapillary area and the RNFL, and we can do for the macular area. What we have to look is the vascular density, because in these patients, the microvasculature is greatly affected because of the death of the ganglion cell. So if we assess the microvasculature in the parapapillary area, then vascular density reduces. And imaging technology uh, has a normogram where it can assess the vascular density in the parapapillary area, and it can compare with the normative data. So that is how it can be little more useful because of the lower floor effect. Similarly, in the macular area, in the macular area, the microcapillary are very, very densely packed. So when we assesses the microcapillaries in the macular area and their vascular density, and then you can compare and you can assess that the patient has progressed or patient has not progressed. So OCT angiography may be more helpful to us in assessing the progression as compared to routine OCT, which is not at all helpful in advanced and end-stage glaucoma. You can see over here, that is the foveal avascular zone, which is significantly enlarged on the image on the right-hand side, as compared to this, where the foveal avascular zone is almost normal. And you can see that, there is a significant capillary dropout or the non-perfusion area in the macular area in this patient. This is an end-stage glaucoma, and this is a patient who has a moderate glaucoma. So there is some non-perfusion area here and there. So in this patient, there is a significant liquid vascular density in the macular area. If we come to the management, then in all these patients, intraocular pressure lower is better. You keep the intraocular pressure at the lowest possible. It is either in low teens or maybe in single digit. And whenever you have to use the medical treatment, most of these patients require the maximum medical therapy uh, until and unless the patient has undergone the surgery and the pressure is reasonably controlled. Then these patients may require either no treatment or maybe 1 or 2 drops to control their intraocular pressure to the desired level. Some of these patients, the laser is very helpful. The SLT is helpful in those patients who are on the maximum medical therapy and still you have not achieved the desired intraocular pressure. So you can do the SLT and you can reduce the intraocular pressure by around 2 to 3 millimeter more. But the micropulse, the cyclo G6 and the CPC, the cyclophotocoagulation, is very helpful in some of these patients who have a very advanced or end-stage glaucoma, and the pressure we are not able to control, and we have a great fear of patient having a wipeout phenomenon. Otherwise, the trabeculectomy and the valves are the gold standard procedure for this patient to achieve the target intraocular pressure. MIGS again is the same when you have a fear of having a wipeout phenomena and you don't want to open the intraocular chamber significantly, then you can do the MIGS and you can achieve further lowering of intraocular pressure by around 4 to 5 millimeter of mercury. If you are doing that, then probably it may be more. So if your patient has to be on the medical therapy, then in majority of these patients, you have to use the maximum medical therapy. And what is the maximum medical therapy? Give them the 3 bottles. 3 bottles may have 5 drops. That is the prostaglandin analog, beta blocker, brinzolamide, brimonidine, and the rho kinase inhibitor or the pilocarpine. Sometimes you would like to give all the 4 drops, but it is very, very difficult for these patients to tolerate so many drops, and very difficult to remain compliant because they have to put the drops entire day. And if there are so many drops, then because of the preservative, and they always have a staring look, so they don't blink often. Because of all these reasons, they have a tendency of having a dry eye. And if there are so many SPKs over the cornea, then their vision is already compromised. And with so many SPKs, their vision is significantly compromised. So try to use the preservative-free drugs. They are available at the same cost nowadays as the preservative included drops. So Novelia Unips we don't have, but most of these drops come in with the Novelia technology. And always use the lubricants so that you can avoid having so many SPKs over the cornea. So main disadvantage is the cost of medication, the multiple drug and the poor compliance, and the drug intolerance and the dry eye. You can see that because these patients have to be on medical medication for a very long time. So they develop these kind of complications. This is because of the long use of alpha-2 agonists. You can see the significant excoriation over the skin and lots of skin allergy. And you can see that this patient was on the prostaglandin analog for a very long time. So this is a prostaglandin-associated periorbitopathy, which is very bad cosmetically. So these patients are very prone for these kinds of complications. About the alternative therapy, there are so many things are available like citicoline and mementin and antioxidants, curcumin, and yoga meditation. So out of all these drugs, we don't have we have some anecdotes available. We do not have any significant proof in the literature that these drugs are very helpful. But definitely the meditation is very helpful. Ask your patient to go for a brisk walk, do the meditation, so they can have a quality spending of their time, as well as probably they can lower their intraocular pressure by around 1 to 2 millimeter further. But the surgery is the best option for these, and the gold standard remains either the trabeculectomy and the valves. The laser procedures can be performed, if you are so much scared of the washout phenomena and so on and so forth, that you don't want to take this patient for trabeculectomy. Are the valves, then you can go for the laser procedures. MIGS is little reserved for the advanced and the end stage glaucoma. And there is always a risk of the wipeout phenomena. The wipeout phenomena is not so common. It is the incidence is less than 1% population, but yes, it does happen. And in many of these patients, it's reversible as well. So that is because of the sudden change in the retinovascular circulation, because of the sudden lowering of the intraocular pressure during the surgery. And to avoid this, then you have to avoid the sudden lowering of the IOP during surgery. And please don't give the retropulpal block, because it is very much responsible for having the wipeout phenomenon. And these patients many a time require multiple surgery. I have done even up to 7 surgeries in one of my patients to control the intraocular pressure. But somehow you have to achieve the target pressure which you have set for these patients. Either you have to do the multiple trabeculectomy, or you have to put the valves after failure of trabeculectomy, and you have to, but still you have to achieve the target pressure. If your patient has a very advanced glaucoma or end-stage glaucoma and the cataract, then probably the 2-step procedure is always better. You do first the trabeculectomy, followed by the cataract surgery. Some people would like to prefer at doing phacoemulsification with that, and they would like to achieve some lower down intraocular pressure, and they would like to manage the medical treatment in future. That is okay. And otherwise, the phacotrabeculectomy can be performed. Plus, ask the patient that, always you have to counsel the patient that they have to use some medical treatment subsequent to the surgery, because most of these patients require additional medical therapy. So, the laser treatment is the last option we have in our armamentarium, and we can do either the diode CPC or micropulse G6 procedure for these patients to achieve the intraocular pressure. how to do the follow-up? Once you have achieved the target intraocular pressure, then once in a month or once in 2 months, measuring the intraocular pressure. Okay, so should I continue with the summary? So the advanced glaucoma is not is the condition which is seldomly seen in our practice, but it is pretty common, and it's always a very challenge to all the glaucomatologists or a senior glaucomatologist. And how to lower the intraocular pressure is a very difficult task, and it is always better to diagnose this patient with 10 days 2 strategy, and OCTA might be little helpful in these patients, but still, it's not a very granular modalities to assess these patients. But still, probably in future, they hold lots of promises. Maximum tolerated medical therapy is often required in this patient. Keep always surgical options open with the risk of wipeout phenomena very well explained to the patient if you are taking up them for surgery. And these patients may require multiple surgeries. So thank you very much for your patience hearing. And always think of these patients so they can retain some useful vision and they can carry out their at least routine activities in their routine life. Thank you.
Thank you so much, Dr. Pradeep. And many times with your experience, you will understand whether to operate or not to operate. So that is much beyond the theory. So it is your clinical practice will teach you when you can really take up these patients for surgical choice. So I'll just open this podium for others also in Dr. Mayuri and Dr. Manish, Deven, and all our other glaucoma members. So first, we would request the team to put in if you have any additional points to add in, or if you have any questions, please do ask.
Can I ask?
Yeah, please go ahead.
Doctor? Yeah. So, Dr. Vyas, many times comprehensive ophthalmologists also manage advanced glaucoma. So, in your opinion, which is the biggest mistake, or not mistake, but misunderstanding they have when they are managing advanced glaucoma? Because you don't want to lose vision, at the same time, you don't want to take risks on trabeculectomy. I'm talking about a comprehensive ophthalmologist. So, one tip for them. What would be the most
Okay,
common mistake they make?
So the very important thing is that whenever they see the patients with a very advanced or end stage glaucoma, they should be able to pick up the condition, and they should not indulge themselves in managing that condition, because it's very difficult to manage these patients to achieve the target intraocular pressure. It is better to refer these patients to those glaucomatologists who are well versed with this condition, and they can manage these patients, and if required they can perform surgery diligently and can preserve the vision whatever the patient has got, and can do the long-term follow-up, because these patients require a very frequent follow-up and very good compliance. Then only they can retain the leftover vision. Otherwise, it's very, very easy for these patients to lose the vision. And everyone must understand that, we have around 12 lakh ganglion cells, and they die 10,000 every year. So when you have an advanced end-stage glaucoma, then there are hardly 90,000, 80,000 ganglion cells are left. So you have to preserve these, and remember one thing, that they will continue to lose in spite of your treatment around 8 to 10,000 ganglion cells every year. So they are likely to use their remaining vision also in spite of your good treatment over a period of time. So that's why the counseling is very, very important in these patients.
Thank you.
Can I add one point to this?
Yes, please.
You have covered, Pradeep, everything. But what I do is, I do a lot of diurnal variation also in these patients. Sometimes there is a fluctuation and we are missing. We think that patient is on a low, but it may not be on the low. Secondly, counseling is done so many times. Chair time is given to the family members also to show them the risk of progression. And then trabeculectomy enhanced with the mitomycin C, but I take releasable sutures also. So that also prevents the softening of the eye. So some of the points, if we keep in mind, will save the wipeout. I do give
Yeah,
mannitol if the pressure is on a higher side before the surgery.
yeah. Regarding the diurnal fluctuation, when your target pressure is so low, when you are looking in a single digit or in a low teens, and the patient is on so many medication or has already undergone a surgery, then you have already blunted the diurnal curve. So usually these patients with so many medications and surgery in their eyes, they don't show the spikes, significant spikes when you do the fluctuations in these patients. And when you are performing a trabeculectomy, yes, you have to take all those things in your mind that before the surgery, their pressure should be controlled and not only should be controlled because these patients have a very advanced glaucoma or an end stage glaucoma, then it should be in the low teens before you take up these patients for surgery, whether with the systemic acetazolamide or intravenous mannitol, whatsoever it is, but the pressure has to be normal and the releasable suture and antimetabolite is the gold standard, and probably all of us are using it very regularly and has to be used.
Dr. Pradeep, there is one other question. When we are operating these patients, say they have already had 2 failed trabeculectomies, so you are thinking of putting valve. Now you have the option of putting the Ahmed valve, which is a valved device, or you have the option of putting RD or some, which is a non-valve device. So basically, the studies have very clearly shown that non-valve device ultimately achieves lower pressure than the valve device. But in the first 2 or 3 months, 2 months, the non-valve device, because you are ligating it, the pressure spikes are likely to occur. Now, a patient with advanced glaucoma, whether they can take those pressure spikes. So you have to decide whether you are going to use the valved device or the non-valve device. So what is your take on this?
See, Manish, it is 100% that we would prefer to use the non-valve device because with the valve device, you don't achieve that low intraocular pressure. That is one. And there is always a hypertensive phase. So if the hypertensive phase is lost for 3 months, 4 months, then you are in a big trouble because immediately after the surgery, you have to put the patient on an additional medication. So the patient will always have a feeling that either the surgery is not successful from the beginning, or there is a likely that the glaucoma may progress in that very short window, which is of 3 to 4 months, when the patient has a hypertensive phase. So non-valve device is always a preferred option for these patients.
All right. So thank you. We will have some more questions to both of them. So one, Dr. Mayuri, the question is, what is that makes you to
Dr.
do?
Mayuri, what is the role of
Sorry, Dr. Pradeep, you wanted to ask? Dr. Pradeep?
He's frozen.
Okay. So I'll just direct this question to Dr. Mayuri. Dr. Mayuri, what is that which makes you to do gonioscopy in every one of your glaucoma patient? Is that you do, first of all, that is the part one. And what makes you to do in every given patient? Though you might see that anterior chamber is normal depth, and then you can come to some conclusion of, okay, this is going to be okay, the angle is okay. So is that you still do the gonioscopy in every given patient?
I do gonioscopy in all my patients.
Okay. So the problem is in gonioscopy is that we don't have that drive to do the gonioscopy. That is the reason, one of the reasons why it goes in for failure. Majority of the time, though it is been taught in every conference, every CME programs, in every medical college or the private colleges, everywhere. But most of the time, the gonioscopy is not being touched or used because of practical problems at the clinic. So what really makes you to do the gonioscopy in a very given patient? What drives you to do the
Shallow
gonioscopy?
chamber. Any patients with a shallow chamber, I would like
If
to
it
do.
is a normal appearing chamber, would you still do the gonioscopy?
If see, I have never done like not doing colonoscopy, but
All right. So the simple reason why I'm asking this question is whenever we see the normal depth of anterior chamber, it does not necessarily mean it is open angles. So that is
yes,
one of the take-home messages that I wanted to say.
okay,
And the second part is gonioscopy will give us a lot of idea what is really happening in the angle. We
yeah,
might miss the new vessels, the pigmentations, the synechias. Many surprises will be there in the angle if we do and see the gonioscopy. So that is the reason why it is always better to do the gonioscopy, even though it may not really, when you don't do the gonioscopy, it is not that every case is going to go for an, the pupillary block glaucoma or an angle closure, but it will give you a lot of idea of what is really happening in that particular patient. So that
yes.
is very important to do the gonioscopy.
It should
And
be repeated
which
after doing any
lens, yeah,
procedure.
which lens you would prefer to use in your
I
gonioscopy?
I am used to size 4 mirror cornea lens.
So is that the ones the photographs were used? You have used the 4 mirror.
The photographs were taken with another lens.
Mhm.
That special lens is available, which is very good for the photography.
If you can remember, can you just tell that name?
Uh,
Yeah, you are same as
it is
me.
not done with the 4 mirror. It's done with the.
Many
For
times,
taking the photograph, the Goldman single mirror lens is the best.
Yes, I have
And
used
for
that
yeah,
also.
and
so
for
we can
doing the
use, yeah.
gonioscopy, you must give the message that the Sussman 4 mirror is the best lens available, and it is probably the cheapest.
So using photography, it is better to use the SLT lenses from either
Yes,
from Oak or Ocular, either one you can use.
I
Gives an
use Latina lens for
yeah, that now
SLT,
you can use, yeah. So you can
and
use those lenses where you can, like
yeah,
the clarity of the images is excellent. So it is not the normal gonioscopy when you do with your ocular or other lenses. It may not really give you this kind of a wide angle view like
yes.
you get with your SLT lenses.
Mm.
So photography part of it, it is better to use those lenses. So just focusing on Dr. Pradeep's talk, is
Yeah, I
that
lost connection in between. There was a power
yeah,
cut down for a
yeah.
brief time. Yeah.
So when you are seeing the patient with an advanced glaucoma, what is that one? What is that criteria that you have? When would you go for a surgical option? Say, for example, the patient comes with a 40 IOP. Is that you feel that the assessing the compliance in the first phase itself is going to guide you through to go for the procedure? Because the reason is more than 50% of the patients, they don't come back for the follow-up at the end of the first year itself. So when you have
Satyan,
advanced
for
glaucoma, would
yeah,
you really go with quick surgical choice to these kind of patients, or would you still ask them to continue thinking that these patients might have the wipeout?
so for me in my practice, there are two absolute indications for the surgery. One is the pediatric glaucoma, and the second is the end stage glaucoma. When the patient comes to me with the end stage glaucoma, whether it's a virgin eye or whether the patient has undergone surgery, I always give them a first choice of going for the surgery. If the patient is not willing for surgery for some or the other reason, then only I put them on a medication. And if I put them on a medication, if I have achieved the intraocular pressure, what I want it to be, but still in every visit, I give them an option to go for the surgery. Because, medical treatment is not so great thing when you have a very small window left to save their vision.
Absolutely.
If they
That is
are
one of the
poor
reasons.
compliant, if they miss the medication, if they develop, the side effects to the medication, and if they don't have a domestic help to put the medication, there's so many issues with the medication. They develop severe dry eye. They develop 2+ SPKs, then also their vision, quality of vision goes down significantly, and they become handicapped. And they come to you and they say that, just few days before I was reading the newspaper, now I can't read the newspaper. So I want them to be on the least possible medication. That's why my choice is always to go for the surgical procedure.
Yeah, see, that is one of the main reasons I've asked you, because the patient's aged about, say, 40 or 50 years old, and then looking at their life expectancy, say about 85, 90, the remaining 40 or 50 years, if they have to be on medication with a tubular field, there is a likely chance that he is going to go blind maybe quite sooner. So offering them a surgical choice, provided that you know how to do a proper trabeculectomy, is always a better choice, or you better refer the patients to those who can do a proper trabeculectomy than just doing a trial and error. Because just because we said that end-stage glaucomas probably requires surgical choice, it doesn't mean that you just go and do the trabeculectomy unless you know how to do it properly.
We have a very less breathing space in these patients. So there is no scope for experiment.
Yeah.
And one failed trabeculectomy means you have reduced the chances of success of subsequent trabeculectomy to significantly lower, at least 10% lower.
The ultimate idea in the end-stage glaucoma is kind of being aggressive to have the lowest IOP possible, so that the vision can be, whatever the vision they have, can be saved for their lifetime. A reasonable quality of vision they can have. So thank you so much, and thank you so much, everyone. Manish, do you have any other questions to ask or add some points?
No, thank you. That is good.
Because it's just we are running a little late now.
Mm.
So thank you, everybody. Thank you, Dr. Mayuri, for the wonderful talk, and Dr. Pradeep for your, again, a wonderful talk from both of you, the good masterclass. So we'll
Thanks for
see
opportunity.
you tomorrow at same time, 8 p.m. for the last session of the online webinar tomorrow. Thank you so much.
Thank you very
Thank
much.
Good
you.
night,
Thank you very
everyone.
much.
Thank you
Bye.
so
Good
much,
night.
all of you.
Good
Bye.
night.
Bye. Good
Bye.
night.
Good night. Bye-bye.